Are we online?
No, not yet, Dr. Mendoza. We are going to go just a minute.
From my side, we could start. I'm ready.
So, good morning, good afternoon, and good evening to everyone all over the world. Welcome to this MOH Connect on our platform, the Medical Online Hub by Vascular Group. This is the first time of its kind to have a format to bring to life what actually you have asked it for. So we received so many requests asking to have more practical, hands-on, live streaming workshops, and here we are, and at Dr. Mendoza Clinic here in Germany with the real life cases, but also we'll go to Dr. Tobias Hirsch Clinic to share some knowledge and experience. The goal of the Medical Online Hub is actually to bring together medical experts throughout the entire world and to discuss state-of-the-art topics in the field of the venous-lymphatic disorders. So today, we have three top-notch experts, Dr. Mendoza, Dr. Hirsch, and Dr. Omar Farouk. As we all know, Dr. Mendoza, her books actually and the research, especially on ultrasound, are reference to many specialists in this field. Same for Dr. Hirsch, his studies and publication on compression are really significant and second to none. And because at Sigvaris Group, we strive to promote the exchange of scientific knowledge on a global scale, while also giving you the possibility to actively participate and to be a part of discussion via the chat and the Q&A function here on the Zoom platform. So please feel free to send over any questions or comments that you might have so we can really discuss it directly with the speakers live. On a personal note, I'm really looking forward to such a special event and to have a very dynamic and but also lively streaming and wish you all a wonderful, fun MOH. Having said that, I have the pleasure also to co-moderate and to introduce our principal moderator and the senior medical advisor of the MOH platform, Dr. Muhammad Omar Farouk. Dr. Muhammad Omar Farouk is a well-known consultant vascular and endovascular surgeon who actually specialized in advanced endovascular and open surgery for critical limb ischemia and diabetic atherosclerosis. He also has extensive experience in complex endovascular surgery for aortic aneurysm and lower extremity occlusive disease, as well as hybrid surgical technique on peripheral venous disorder, varicose vein, and dialysis access. Dr. Muhammad Omar Al-Farouk earned his undergraduate degree at Ain Shams University in Egypt in 1983, and he completed his postgraduate vascular surgery training at the West Midland Vascular Rotation in UK. He obtained the fellowship of the Royal College of Surgeons in England in 1994, and he's also now a Royal College examiner in England. After completing his training, he joined the general organization of the teaching hospital and the institution in Cairo. Dr. Omar Al-Farouk is very well known in his enthusiasm when it comes to education, research, which include simulation courses design, milestones and different skill training. He is also having numerous research that have been published, and they're giving many presentations in different very well-known congresses all over the world. He always also inspired us. By the way, also the MOH was part of his inspiration. He's one of the pioneers, started the VOTE, the Vascular Online Training Platform, which is available in different channels, YouTube, Facebook, Telegram, so many, for a long time ago, with thousands of followers. And if you are not following the VOTE, of course, with the MOH, you are missing a lot if you are really looking for more education. So with that, I hand over to Dr. Omar and wishing everyone insightful and interested MOH Connect. Here we go, Dr. Omar.
Okay. Thank you very much, my dearest Dr. Mahmoud Al-Ghadban, for this very nice introduction. And actually, all this great effort is done through your ideas and your activity, which really inspired all of us. Let me take the opportunity to present my dearest Dr. Erica Mendoza, Professor performing duplex ultrasound in diagnosis of leg veins. She also advocate of Chiva procedure. And if you haven't done Chiva procedure, you just attend one lecture of Erica Mendoza, you will become a big fan of Chiva procedure, what happened in us in Egypt. She is also the president of the German Phlebology Society, and she is a winner of the award of the best German phlebologist. 20 best German phlebologist. She came first 2018, 19, 22, and I nominated her for 23 and 24. And we're very eager to have her and to enjoy the knowledge of my dearest Professor Tobias Hirsch. After that, I will indulge him with his well-deserved introduction. So the mic to you, and we are all eager to learn from you, Dr. Erica Mendoza. And please accept our apology for too many questions will happen when you are working with the duplex. Thank you very much.
Thank you so much for this kind introduction from both of you. I would like to start showing the room and the setting. So please, if you could enlarge the Erica Vein Clinic image. So I show you, I don't know, it's large. This is the place where I work. My patient is standing on this podest, and I have the device here. I use my probe with the hand, and I have a second screen here to preserve my neck from being always looking like that. And when I do endoluminal treatments or foam sclerotherapy, I have the patient on this bed, and I have a third screen over there, again, for my neck. I'm an old woman. And then I can treat very relaxedly everything. So now I would like to bring the patient into the room. Yes. Things happen like always. I had a lady with refluxing great saphenous vein, which is ill with corona since 2 days, and I had to look, and I found a lady. She has a small saphenous vein reflux, but she's very lovely and she's very skilled in workshops. She's always with me since, good evening, since lots of years and doing online and present workshops. And I will just start having a look at the veins. And if somebody has a question, please don't hesitate. So I don't know if you see the legs properly.
Dr. Erica, can you just wait a second?
Yes.
Khaled, can you please spin the screen of Dr. Erica Clinic so the audience can see it in the big screen? There is three dots on the top corner right from the.
And I share the screen of the ultrasound, yes?
Oh, no.
This, yeah. Okay, so this lady has small varicose veins on the back part of the calf. She has no edema, no discoloration, and this is why I have her as a wonderful model for my courses since lots of years, because there is no progress in the disease. But I will start looking at the great saphenous vein junction. Yes, einmal umdrehen bitte. So do you see my ultrasound screen? Yes.
Yes, we can see it, but we don't see the patient and where is your probe and how you are holding the probe.
Okay, this should be the vein clinic. Mahmoud's iPhone should be this. You don't see that?
I think if people are using the mobile, and then they will not be able to see the screen, the full screen. They need to move the screen to see the different options to have only the one screen of the clinic.
No, you need the screen of the ultrasound also. You need two screens.
Yes. Yeah, we can see the screen. Yes,
I can see it from the. I'm sitting at the desktop at the computer where I can see it clear. But if someone using mobile, then it will be hard for them to see it.
Yes. How shall we solve the problem?
And now we are showing only one screen. We're not showing two screens because people are asking if they can see two screens. We are showing one screen, big screen, the ultrasound image. But from the other side, you will see the patient as one of the speakers screen.
Yes. Okay. Can I start?
Yes, you can start. Yes.
Yes. Okay. So I will start the right groin. It's always good to have some jelly. And this is the classical Mickey Mouse.
Yes.
Sorry. This is the classical Mickey Mouse with a small ear because the great saphenous vein is healthy. Yes, this one. This is the artery, the deep vein, and the junction of the great saphenous vein. And if you put color, you can see the flow in the artery. I don't know why the image, I will make another preset, I'm sorry. Oh, looks like, okay, you see it properly, yes?
Yes, I can see it very well.
Okay.
The gray image is very well, yes.
Then I always say this is the phlebological artery investigation, which is like only in cross-section. And this lady has 3 spikes. So for the first moment, I think this is okay. I move to the deep vein and I make the classical thing, which is calf compression.
Okay.
And I elicit a good anterograde flow. But then I will make another thing. Einmal die Zehe heben. This is the toe elevation. I don't know if you see it, toe elevation and down. Wieder runter, genau. Mal warten kurz, das muss nämlich wieder auffüllen. Und nochmal heben und runter. So the toe elevation and the calf compression elicits a good anterograde flow in the groin in this lady. Of course, we can make Valsalva, but in standing position, this is not so kind. So I will go back to color. And we see that the saphenofemoral junction with compression of the calf has no reflux, but we see a vessel here. And we have to discern if it is an artery, the one crossing there. No, this is very interesting. I didn't expect it. Last time it wasn't there. We see a flow towards the probe, which is red in the image and going up here. And this is a drainage from the epigastric. I'm now tilting the probe to the tummy. And I see this is the vein coming from upstairs, the epigastric vein. And there is a reflux longer than 1 second, of course. And of course, this is a flow in the correct direction because obviously the epigastric vein drains to the leg. but it should flow only 1 second.
Okay, so
I
your
make a
definition of reflux is anything more than 1 second, not more than half a second.
For me, it is more than 1 second, yes, because
Okay.
Labropoulos in his wonderful work examined healthy persons and noticed that everybody of the healthy ones has less than 1.5 seconds. But if you make studies like I published on people with reflux, it is always like 2 or 3 seconds, but for sure more than 1 second. And this
Okay.
avoids you from treating people with healthy veins, if you know what I mean.
Yes, I know what you mean. This is a very good advice for people in order not to treat from half a second to 1 second. This is debatable, but definitely more than 1 second we all agree upon. Thank you.
Yes. And another interesting thing is that sometimes you make like I will do it again in the deep vein. In some patients, there is a difference between the compression of the calf and the toe elevation. Einmal nochmal anheben. So if you don't have a reflux with one of both, but you have a varicose vein, you should always test with the other there you see me, with the other modality, just to make sure that there is not a problem of the muscles or a problem of the calf compression, because in some patients you have no reflux with calf compression and you have a reflux with the toe elevation. But we will come to this just in a second. So we have this flow now, which is a reflux from the epigastric vein, which is in the correct direction because epigastric vein drains down to the confluence with the great saphenous vein and then to the deep vein, but it is long lasting.
Yes.
I will make a little Valsalva. Holen Sie mal tief Luft. Halten Sie Luft an und pressen und weiteratmen. And astonishingly, sometimes the Valsalva doesn't work in the pelvic reflux, but now there is again a long-lasting reflux in the epigastric vein. And this is very interesting because this lady has a reflux from epigastric vein draining to the deep vein, yes?
Yes.
But not into the great saphenous vein.
Yeah.
The
Do you
great
think this
saphenous,
might be a sign of pelvic congestion syndrome?
no, the pelvic congestion syndrome is when you have a reflux and also symptoms.
Okay.
She has just the pelvic reflux. She has the pelvic, it's the difference between vein reflux in the leg and chronic venous insufficiency. This lady has vein reflux in the small saphenous vein, but no insufficiency because she has no skin discoloration, no edema, nothing showing that the veins are not happy. You know what I mean? The
I know
difference
what you mean,
between
but what is the source of this reflux in the epigastric vein? Where it
the
is
source
coming
of
from?
this reflux is the pelvis, of course.
Yeah.
But to have she has not a pelvic congestion syndrome because this implies that she has symptoms,
Okay.
as to my knowledge. Tobias
Yeah,
better
it's a good advice not to diagnose pelvic congestion syndrome in asymptomatic patients just on
no.
duplex criteria. This is very important.
She has often women after pregnancies or on the right side after if you had an operation surgery on the ovaries or the appendix, the skin was cut and sometimes then you have a pathologic drainage. But in this case, and this is the thing I think want to show you, this drainage, this pathologic drainage is physiologically drained to the deep vein.
Yeah.
Here you see the junction, the very junction, and the blood flows inside the femoral vein and then leaves the leg through the common femoral vein. And this is perfect. So this pathologic drainage leaves the leg through the femoral vein and there is no flow towards the leg. And this is what I always say when we treat patients with reflux source in the pelvic system, like her, and we close, this is the epigastric, this is the junction, this is the saphenous vein. If we close the saphenous vein below the junction, we leave the drainage from the refluxing pelvic system through the ostium and don't generate a neovasculogenesis because we cut all these vessels with a crossectomy. This is why I say when the people has the reflux from the epigastric or the circumflex or the pudendal vein, better not to touch the groin surgically, but only close below.
Yes.
This is
that's a very good advice. Yes, because it's compensated for the reflux.
Yes, now we have the classical thing we always have to do, like a compression, to demonstrate that the artery is not compressible, but the deep vein and the saphenous vein, they disappear on compression. And this is because they have no thrombus. And always, if you do a procedure, you have to demonstrate earlier that there was no thrombosis before you started treatment. And now we are going to the more interesting part of the leg. I'm going to turn around. And somebody has to tell me when I have to stop talking, because when I run out of time always when I'm doing ultrasound.
enjoying your skills in doing duplex ultrasound.
Okay, now just to show the comparison between both legs, this one is the left leg,
Oh,
and
brilliant.
this one is the right leg.
Yeah, we can
And you
see the
immediately
big vein
see-
in the symptomatic leg, yes.
Yes, this one is the small saphenous vein of the left leg, which is healthy. And this one is the small but enlarged saphenous vein on the right leg. And if you allow me another observation, just by the way, you see this is the fascia saphena, the
Yeah.
muscle fascia. And here you see another vessel, which
Yeah.
is a very often found deep vein accompanying the small saphenous.
Yeah.
And the problem sometimes is, on the other leg, she has also one. If this one is refluxive and the superficial one is healthy, it is easy to confound them.
Yes.
But you can't treat deep veins with superficial treatments. So you have to be always aware that there is this fascia and the saphenous vein runs inside the fascia duplication. But now let's go with this small saphenous vein. You find the small saphenous vein at the level of the back of the calf in the proximal segment.
Okay.
And now we go upstairs and to look for the junction. Here
Yes.
you see appearing muscle veins, gastrocnemius vein, the tibial posterior vein, all going together and having at the end I go a little bit deeper, one venous vessel here and the artery. And now we have to sort out, and by the way, here is the Giacomini vein. I'm above the knee fold. There's the Giacomini vein. And I go down again, and here I have one vein emerging. The vein gives muscle veins, and then is the small saphenous. And if you remember Cavezzi's division of saphenous veins, you remember perhaps that he divided, and I think this is very important, he divided two situations. One, when the small saphenous vein goes into, this is a longitudinal, here is the merging point of both, yes, the deep vein and the small saphenous, and further down, a muscle vein goes inside the small saphenous,
Yes.
draining into the small saphenous. So if you would follow the ancient rule to say you cut the saphenous vein at the junction to the deep vein, you would also close one muscle vein. I go back into transversal, common vein, one vein only, popliteal vein. I go down. This is the
Yes.
small saphenous vein, and immediately after it divides into muscle veins and the small saphenous vein. And if you make it like you should surgically, you would close it here.
Yeah.
And you would close these both. So it is very important to be aware before you treat the patient, to be aware on ultrasound if there is this situation, because then either you do it endoluminal or you do it surgically, you shall not close the vein.
So you preserve
Higher
any
than this,
muscular
yes.
veins.
You have to respect the muscle veins, yes. You have
Oh.
to close here.
What
Yes?
What happened if accidentally one of them is being closed? Does patient become symptomatic in the cuff muscle?
I have seen patients with muscle vein thrombosis. Well, I mean, it is not periculous because there is no option to be a pulmonary embolism because it's closed.
Okay.
But it is hurting. It is hurting a lot. So now we go on with the reflux we have talked about. I go back to the bigger image. Okay. I make a calf compression release. And you see first a quick one and then a long lasting reflex. And if you see here the seconds, it's half 1.5, 2.5, 3.5 seconds. Yes.
Yes.
Now I make another kind of einmal die Zehe heben, toe elevation and back. Nochmal und runter. And you see, in this case, the calf compression is better.
Okay.
Yes?
Yeah.
It depends on the person, on the situation. I don't know why. And one thing I want to demonstrate, even though in this case the reflux is very obvious, is my loveliest maneuver. Einmal bitte hinlegen. Geht das? Ja, ne? Und einmal bitte, ich stelle mich mal davor, damit man es von der Kamera aus nicht sieht, einmal das Bein. We elevate the leg of the lady so that the veins go empty. And this maneuver, the dependency maneuver, is best in patients where you see, there is a vein, it could be varicose, but there is no real reflux. And you will see the difference now. Einmal wieder runter, ich stehe vor Ihnen. Einmal wieder hinstellen und umdrehen. She gets up and turns around. And I go through to the vein. And you see it is filling and filling and filling and filling and filling a long time.
Yes.
Yes, and this maneuver is very good in patients where you think there should be a reflux, but you don't see it. Because it is not dependent on anything, not on my hand, not on the muscles. If the leg is empty and there is a valve not closing, you see it is still the same reflux. So this is really a good way to sort out, and this is the queen of all the master of the reflux provocation maneuvers. Because if you don't have a reflux after this maneuver, there is no reflux.
Excellent. That's a very nice maneuver, and I would suggest to call it Erika Mendoza maneuver for provocating reflux.
No. It's published as dependency maneuver. It's very funny because in the same year, we didn't know each other. Chris Latimer and me published it in different places. And I called it orthostase maneuver in German, and he called it dependency maneuver in English. So it is not only my thing.
Okay. I will personally call it Mendoza maneuver, but anyway.
Okay. But this is the only one reliable always.
Okay. It's a very good provocative maneuver. To be sure, you did show it quite obviously that it is very, very clear, and sometimes you don't detect reflux, even if you're examining patient at the end of the day, and it is different. But when you do this provocative test, you can definitely diagnose it very easy. That's a very nice information. Thank you.
Yes. Very welcome. And this now is the junction. We can have a look at it in longitudinal view, which is always very didactical. So this one is the popliteal vein and the artery below. Yes.
Yes.
And then you see in the deep vein a reflux. And now I ask you, has a lady a deep vein thrombosis in the post-thrombotic syndrome? What do you think? She has a reflux in the deep vein.
Yes, it looks on the color, but you need to confirm it with power angio and with waveform analysis, with Doppler sampling. We don't rely on reflux on just a single color image.
Okay, I will show you something. Heben Sie mal die Zehe und runterlassen. Suddenly she has no longer a reflux. And I loosen my finger. Nochmal die Zehe heben und runterlassen. This is the problem with the maneuver in her leg. The problem is this lady has a reflux in the deep vein because the deep vein empties the blood, drains into the saphenous vein.
Okay.
So the source for the reflux in the small saphenous vein is the deep vein.
Okay.
And this is why between the next higher perforating valve and the opening of the small saphenous vein, the blood is going down and draining into the small saphenous.
Yes.
And as in the moment you close the small saphenous, the reflux will stop in the deep vein.
Okay.
Was that understandable?
It's understandable, but how come the pressure? Because you know the deep system have very high pressure, and the subcutaneous system have little pressure. So how it can fill from short to deep vein? Because pressure-wise, it should be the opposite.
Yes, but if you make a compression,
yes,
have a look. I'm trying to center And longitudinal is not so easy sometimes. If I make compression and release, geht's Ihnen gut?
Yes.
Ja?
Yeah.
Alles gut? I go to, just a moment. So, if I make compression and release, I have a reflux
You have
into the
reflux,
small
yes.
saphenous vein.
Yeah.
And the blood, which is now filling the small saphenous vein, where does it come from?
It should be coming from tributaries of the short saphenous vein in the leg, or is
I
it
now
coming from
push
the
it.
deep system?
Yes, I push the blood upstairs now.
Yeah.
Wait. I push it upstairs into the deep vein, and then it comes back from the deep vein into
To
the superficial vein.
Yes, yes. Now we can see it very
You know what
clearly
I
with the
mean?
color. Yes, I know what you mean. Yeah.
And if I close the perforated tributary and then I open it, you see, when I close
Yes.
it now, there is no more reflux. And when I open it, there is a reflux.
Yes.
So the deep vein at this segment is draining into the superficial vein.
Yeah,
And this
that's
is not
true.
a deep reflux, but it is the source of the reflux of the superficial vein.
Okay. Yeah, I can
This
see
is
it very
something
clear. Yeah.
to think about. Now I make a longitudinal, because we have here a valve. I go back to a little higher resolution here. Oh, no, there is the valve. You see this little segment here?
Yes.
You see that this is the shape of the valve. It is very thin and tiny,
Yes.
but the vein is a little bit enlarged because there you have the starting here.
Yeah.
Here and here, the starting of the valve.
Yeah.
And if we go further down, and often these valve segments make this enlargements. Yes?
Yes. Yes.
I go to the longitudinal and we go further down.
Or maybe the
But normally,
enlargement is making the valve incompetent.
and here is another valve. Oh no, here is a tributary going
Yes.
out the vein. We will examine it.
Yes, yes, very clear. What is your definition of perforator? Do you think of 3 millimeter as your definition?
This was a tributary. This was not a perforator. I have
Okay.
a look if I find a perforator. This was a tributary because it went. Wait. It leaves the fascia over there.
Yes,
It goes
yes.
out.
Okay.
So it is a tributary, and it is refluxing. It is red. Yes.
Okay.
I go down for sure. We find the perforating vein. This is another tributary going to the other side.
Yeah, very clear.
Yes. And then we have a look. There is a perforating vein because it goes into the muscle. It
Yes.
doesn't pierce the fascia. This is a tributary, and the tributary gives, here it goes through the fascia
Yes, yes, very
into the
clear.
muscle.
Yeah, very
Yes?
clear. Yes.
Okay, and then we have a look. This is so difficult in these cases to define the direction because they are tortuous, and einmal die Zehe heben und runterlassen. It doesn't look like very much involved.
Yes. There's no
And
much
if
reflux
we have-
coming from it. Yeah.
No, and if we have a look at the diameter, I measure the diameter next to the piercing point. I mean, like here, for example.
Yeah.
But the pathology of the perforating vein for me, it's 2.5. It's not depending on the diameter, but on the flow direction. If the flow direction comes from inside to outside, it is a pathological one. It looks like here we could have a better image.
Yes, yes, very clear. I will leave the time management to my dearest Dr. Mahmoud Al-Ghadban because I'm enjoying your duplex. I can stay for hours. So I think he he will give us the when we time to change. But it's very, very skillful to get this picture. I want to show everyone
yes.
that with your hand
You're very welcome to visit me and see me.
Yeah.
So let us have a look if one of those goes into the fascia here, and to see a properly draining perforator. This is there it pierces the
Yes,
fascia.
yes, very clear. Yes.
Yes. and you see that the most of the segment is blue.
Yes.
And here you see very, very clearly that this is a draining perforator. Yes?
Yes.
The blood drains. And this is for me, this is the important thing, not the diameter, but making sure it is draining and not refluxing in the diastole. Yes?
Yeah, that's very nice,
is
important. Yeah, to rely on the direction of blood rather than the reflux in management of perforator.
Yes, yes.
That's excellent advice. And please extend our thanks to your very kind patient.
Yes, of course, of
She
course.
is very
We can
kind.
give her an applause.
Yeah.
And then I think we are finished here, yes? And I
Okay.
go back to the screen. Is that okay?
Yeah, that's
Or
okay.
any questions?
Yes, we'll see.
Okay.
If you put your question into either the comment section, we are delighted to review them. So I will go shall we go for the poll questions, or we take some question from the attendee?
Let us have the discussion on with the experts. Also, Dr. Tobias Hirsch can also give his input.
Yeah.
I think it's also really important for us.
Just a moment. Can you start my video, please? At this place?
Okay.
Okay. Yes, perfect. I'm back.
Brilliant. So let me start by taking the chance of having our eminent professor Tobias Hirsch. What's your opinion about this excellent short saphenous scanning?
Is always learn from the best.
Yes.
To be honest, I always try to do it a very similar way. But I think one of the most important issues is for everyone, especially for those who don't come primarily from the vein examinations, that we need a patient in an upright position. This is how it works.
Yes.
The problem
I'll be back just in a second.
Vein diseases is always gravity.
Yes.
And gravity works always, and we have to use the gravity in order to find out where is the disease from. We don't treat veins, we treat patients, but we have to see where are the causes, which are the causes of skin changes, of ulcers and something like that. And you only can find this out if you use these maneuvers. If you, I think I was very impressed how it worked in this in this presentation with the dependency maneuver.
Excellent. And I learned it from Erica how to respect muscle branches going into short saphenous vein. We as a surgeon, before the duplex go so advanced, we used to do a lot of ligation of short saphenous at the junction of the popliteal vein. But I learned from Erica Mendoza that muscle branches should be respected where it is draining. It can give you complication, venous thrombosis of muscle branches that even can go up to PE. So I did learn that from Erica. Do you have the same experience, Tobias?
Yes, there is also an interesting phenomenon in Germany. We always also watch the muscle veins. It is also very important when it comes to DVT treatment. But we know from international trials that the lower leg muscle veins don't play such a great role. But I think it's always important to watch them, because you can have DVT after having treated the small saphenous vein, after having done sclerotherapy. And if we see calibers like this, like a thumb, we have to be clear that these are vessels then also can produce thrombi for very big pulmonary embolism. And so I think you must not underestimate the role of the muscle veins. For DVT treatment, but also as a cause of reflux, as a cause of leg vein disorders and complaints.
Yeah, excellent. I have a question to Erika. Do you do classification or quantization of reflux as grade 1, grade 2, grade 3, or just reflux more than 1 second, and this is all what you need clinically?
Good question. I always record my images, so I could go back and have a look at it. But for me, it is reflux if it is longer than 1 second. And then I think there are so many confounders on the reflux length, like the time passed since the previous maneuver, if it's summer or winter, and so on, that I think the length of the reflux is so semi-quantitative. So if you really want to have an accurate measurement, you can only make the recumbent standing and wait how many seconds it takes to refill.
Yeah.
Or like Christina Janere made, she made this Valsalva with the 30 millimeters pressure exhalation, or you have to make a calf compression with a device. So to have always the same.
Yeah.
But outside this study situation, the reflux length is really semi-quantitative. And I was completely convinced that the reflux velocity played a role in the reflux source, and I tried to demonstrate it, but I failed. It is completely random. So you can't say, to my eyes, nothing about the clinic just by the shape of the reflux.
Yeah.
The clinic, you have to ask the patient.
Yeah.
It's
Excellent.
no other.
Yes, that's excellent.
No
I got,
other.
This is what we
yeah,
treat.
yeah, excellent. I got a very nice question. He said, would you be so kind to repeat the dependency provocative maneuver, which I call it the Erika Mendoza maneuver for reflux?
Oh, yes.
So if you can tell it, because
Problem is-
everyone is interested to know it.
Yes, I'm so sorry, but the patient left. I'm so
No,
sorry.
it's all
I
right.
thought
You
I was
can
ready.
verbally
I
say what you
repeat, I
do.
explain it.
Yeah.
I explain it. You put the patient, normally this is very well for veins that are very tiny. You have a slim vein and you think, but there are tributaries that are refluxing and you don't see the reflux source.
Yeah.
Usually I do this for a great saphenous vein, which is not so large.
Okay.
And I stand there and say, I think there should be a reflux. Let's test. So I put the patient lying down. I elevate the leg for 20 seconds. And then for people doing it the first time, sometimes it is better to mark with an edding or a pen on the leg where you have to put the probe, because sometimes until you find the place, the reflux stopped. Yes.
Yeah.
But you then ask the patient to stand up again. And then the veins that had run empty with the maneuver, the leg elevation, the leg is empty.
Yeah.
They come on standing again, and it is like sometimes 2 or 3 minutes of reflux.
Yes.
Reflux running, and you can investigate everything.
Yeah.
If you have large veins, the reflux will finish earlier because they are quicker filled.
Yes.
But if you have tiny veins, it will take long, and you very comfortably can investigate the leg.
Yeah, you know, this explain. I done a paper about 10 years ago from our nurses that we used to measure reflux in the morning and reflux at the evening at the end of the shift, and we were surprised that they are not refluxing in the morning, but refluxing grade 1 and grade 2 in the evening. So your explanation. We were doing it without knowing why. We thought, well, maybe the valve get exhausted at the end of the day. But this is very nice test, and I would recommend it to do it routinely to exclude reflux.
Yes. The thing is, I make more investigations in summertime and more treatments in the wintertime.
Yeah.
And I sometimes have patients with an obvious reflux in the summer.
Yeah.
And they come for the treatment of the great saphenous vein, and they have no reflux, with no chance, not with a dependency, nothing. And then I don't treat the great saphenous vein. I treat the tributaries, and often the great saphenous vein remains competent. But this is a thing that depends on the time you are standing, on the temperature, on the sports you have done yesterday, perhaps. I don't know. This is variable.
That's very true. Yeah. What's your opinion, Tobias Hirsch, about this matter of the refluxing situation regarding if you have an empty leg of blood or you have a full leg full of blood?
Because I think especially when the venous hypertension is extreme, in these cases, it works very well because especially in these cases, it is frequently not possible to induce a reflux with the usual distal maneuver.
Yeah.
And then you only have to know that there is an opportunity to make the vein empty. It needs a little bit coordination. The patient has to be able to do that. It's not always the case. But in this cases, you need assistance in your room, and we do it the same way. But to be honest, it's not every day that that it's necessary to do that. And that's why I have one interesting question from Dr. Al-Zakari. He wants to know the best method for confirmation the reflux distal augmentation or color flow and respirational variation. And I think you cannot answer this question with one fit for all answer. There is it might be the same patient where you can induce a reflux with today with this maneuver, and the next day with another one. And it depends on the day. In the morning, as you already mentioned, in the morning the situation is better than in the evening because gravity works all the day, and so you see more reflux in the evening. So as we know that the people suffer from leg pain, severeness of the legs in the evening when they come back from the shift and not in the morning. And so there is a connection between both. And so there is no unique answer which is the best reflux maneuver. You have to try out all, and you can invent a new one.
Excellent, excellent. Do you have a comment, Erika?
No, I'm completely with him. But just to say the respiration augmentation works in better when the patient is lying down.
Yeah.
I really use this. I normally, like Tobias said, I always investigate in standing position.
Yeah.
Also, when I want to exclude a thrombosis, because especially in the calf, you find the veins better in the standing or in the sitting position.
Yeah.
But if I have a person with a large limb and the person comes to excluded thrombosis, and I don't see any thrombosis in the leg, then I put them lying down and compare first the velocity of drainage, because when you are standing, the blood will, the first minute it will just flow out of the leg. And then after a minute or two, you start having the respiratory augmentation if everything is fine.
Yeah.
But you won't have it if there is a central thrombosis.
Yeah.
So the only moment I use this respiratory things is when I want to exclude indirectly iliac vein thrombosis.
Yeah.
Because sometimes you have people with 180 kilos and you can't have a proper look. And then this indirect sign is very, very valuable.
Yeah. I just want to ask a question. A patient once I have seen, she was having a scar in the abdomen, a recent scar from cesarean section, and she couldn't cough. And she had superficial thrombophlebitis in the leg. How can I confirm reflux at saphenofemoral junction? I can't do Valsalva. She can't cough. I cannot press the abdomen or even press the thigh.
But why do you need Valsalva in that moment? You can make a calf compression. You can put it. Could she stand or couldn't she stand?
No, she was lying down.
Yes.
She said she can't stand.
Then the next question, why did you have to know in that moment if there is a reflux? You aren't treating the reflux. You are treating the thrombosis.
Oh, so just in this situation, exclude DVT. That's it.
Yes. You can investigate the reflux when the thrombosis is gone.
Yeah. Okay. That's a very good answer.
You always have to ask the questions that have a consequence.
Yes.
And of course, when I have a patient with a superficial vein thrombosis, I make the workout because I then explain them how to treat later on the legs.
Yeah.
But if you can't do it, in that moment, it has really no consequence.
Yeah.
So it's okay.
Yeah. Because in our reporting of duplex scan, we have an item reflux in that area. So sometimes we feel a bit committed to complete our reporting is to mention. That's right.
Yes, but if the saphenous vein is closed with a thrombus,
yeah,
you won't see a reflux anyway.
Exactly.
Even
exactly.
though, so
Okay.
Just write kindly. We will check on that later on.
Oh, that's a very nice reporting. Okay, I will take one last question from Wasim. Everyone is excited about your very nice clinical skills with the duplex scan. Here's a question from Sayon Pokrel. Do we treat asymptomatic significant reflux without varicose vein and chronic venous disease, but just dilated truncal veins? That's a very good question.
Yes, you have seen this lady is being my model since 7 years.
Okay.
She has a large saphenous vein, and now which I showed you the valve, and this is nearly a centimeter. I forgot to measure it. I'm very sorry for that.
Okay.
And this is now the time I'm starting to think, just because of the risk of a superficial vein thrombosis increases with the diameter of the vein. But she has simply no symptoms. She has no edema, no cramps. She has no skin discoloration. She has no itching. So I do only treat patients when they, of course, when they have a reflux. This is not always the case in Germany. Sometimes they treat patients without a reflux, but I treat them only if they have a reflux and either they have symptoms.
Yeah.
Symptoms you obviously can cure with a compression stocking, yes,
Yeah.
because often you have cramps for another reason.
Yeah.
And it's or the patient is very feeling discomfort with the visible veins. So
Which
if the patient
is
says,
also symptomatic, cosmetic
yes, it's
symptoms.
asymptomatic, but they say, okay, I can't go to the swimming pool because look at my leg, I feel ashamed and so on. Then I explain to them that we don't know how long it would take her or him to develop symptoms.
Yeah.
But we know that if we treat in 5 years, the possibility of having a retreatment is 50%. Because this one we know. We don't know how long it takes to get chronic venous insufficiency if you have a reflux. But if the patient says, I can't live with the vein, okay, then I treat it, of course.
Yeah, excellent. So another question from Dr. Hassan Hussein. In the case showed ablation of short saphenous vein up to the junction of the gastrocnemius vein, and if surgically ligated below the muscle junction to prevent thrombosis of the muscle vein. Yeah, I had the same question. So can we do ligation below the muscle as respecting the muscle vein? Would you advocate this?
Yes, of course.
Yeah.
We did. I prefer, since the endoluminal treatment is there, I prefer doing the small saphenous vein endoluminally because it is very elegant and you don't have to. It is more difficult to treat surgically the small saphenous vein than the great saphenous vein because there are so many variables and there is a nerve and so on. But we did it for many years, the prostatectomy, surgically, and we always respected the gastrocnemius veins if they were there. It's 50%. 50% of them have no, and 50% have gastrocnemius veins draining to the small saphenous, and then you have to respect them.
Yeah.
In my eyes.
Excellent. We have another beautiful question again from Dr. Nasser Al-Zakari. He said, can I use varicose vein for bypass or critical limb threatening ischemia or deep venous arterialization? Is it usable for us as a surgeon? I would like to know your opinion and Toby's opinion.
Definitively. So you want my opinion or yes?
Yes, definitely, yes.
So definitively, I think until a diameter of nearly 1 centimeter in the groin, which means like 7 millimeters in the thigh, you can use the vein because they recover. And I know not everybody is fine with Chiva, but if you do Chiva, you demonstrate that closing the reflux source, the vein recovers. And we are just making a revision about among the Chiva group, how many of the people treating not only veins, but also arteries have already used a vein, formerly refluxive vein after Chiva. But I'm convinced that you can use a not too much enlarged refluxing vein because the muscles of the saphenous veins are very, very strong and they are able to rechange. Imagine you take a saphenous vein and put it at the coronary artery bypass where the pressures are completely different and they adapt.
Yes.
So also a slightly adapted, dilated saphenous vein should adapt, I'm sure, for this, but I don't know if there is literature using very refluxing. But after Chiva, we are putting together the literature, and we have already 20 cases that this worked.
Excellent. That's a really a
One
very
comment.
good. Yes, please, Tobias.
There is one very important issue. It is to have this question. This is what we have to do. Is it possible that we need this vein for not only for critical limb ischemia, also for coronary bypasses? This is the question to be asked before you ever treat a saphenous vein, especially if the diameter is not that big. So probably the varicose vein disease is the smallest problem the patient has.
Yes, that's absolutely right. We always worried as a surgeon that the vein will rupture if he's refluxing, if he will get an aneurysmal dilatation. And sometimes we prefer to take radial artery rather than deceived vein. But I think this information is not totally verified. I think the opinion of Eric is that if you have small reflux with good muscle wall, with no obvious disease, you can use, and this will dramatically change. But I think we need to go to some animal models and work about that because, yeah, yes, please, Erica.
Now you're telling this, I remember a case, but this is 30 years ago, because my first husband died 20 years ago, and he told me the story. They had a patient with a refluxing great saphenous vein and a closed superficial femoral vein, which is now no longer called superficial, but I mean a closed femoral vein, and they just took the cross, the junction, put it on the artery, and took the distal saphenous vein as it was, the valves were not working, and put it to the popliteal vein, and they had an in situ bypass they used because the vein was refluxing.
Yes.
And it worked perfectly.
Yes.
So you don't have to turn it around. You can leave it as it is if the valves are broken.
Yes.
So you can use the benefit of the refluxing vein to make the bypass.
Totally agree. That is
I
very
don't
valuable
be the bad guy, Dr. Omar, but I'm sorry.
Yes.
Dr. Erica, it looks your topic is really good, good topic, and they're very interesting to everyone. And I'm sure in the future they were actually discussing to do more like a series of MOH Connect more workshop with different indication. And I think now, because now we're using the time of Dr. Tobias, it's
Yes,
almost
please.
1 hour only discussing the first part. So I'm really happy with the dynamic and active discussion. This also shows that that was the right topic and also the right moment to discuss such things. And we also encourage the same. So for the audience, of course, you can continue sending us your questions. Please follow and subscribe to our newsletters, and we'll keep you in touch with also our eminent speakers to get back to you and answer your questions. So now I would really ask you, Dr. Omar, to move to the next presentation. Thanks so much, Dr. Erica Mendoza. You know, I'm here in the clinic. I was really eager to move from this room to come to see how you do it with the patient. But now I think it's your turn, Dr. Omar, to introduce Dr. Tobias Hersh.
Excellent, very much. Thank you very much, Erica, for a great lecture. Let me introduce my dear friend, one of the very eminent philippologists, not just in Germany, but all over the world. Professor Tobias Hersh. He's a specialist in internal medicine and angiology, board member of the Professional Association of Philippology. He has been invited as a speaker and lecturer in many international vascular conferences in Germany, in Europe, in United Kingdom, and United States. In 2020, Tobias Hersh has chaired the 62nd International Annual Conference of German Society of Philippology. He is a board member of both German Society of Philippology and Professional Association of German Philippologists, and he's also the executive board member of European College of Philippology. I always enjoy your research, always enjoy your lecture. We are all ears, your great presentation, Tobias.
Dear Dr. Mohammed, thank you so much for this kind introduction. Can you already see my slide?
Yes, I can see it very well.
So, ladies and gentlemen, and now I'm very happy to add some information and news about one of the most important instruments we have in phlebology, and that's compression therapy. My aim is to provide information about current developments in this field and to explain how I use it. Despite all the innovations, this type of treatment has a long history. These are my disclosures. I took this photo in Klatovy, Bohemia, in the Czech Republic. These are monks who were buried 350 years ago, excellent preserved mummies. And I made a great discovery here. This monk definitely suffered from lymphedema, I think. And what type of treatment did he receive? The answer is bandages, compression bandages. I was totally blown away when I saw that. But let's talk about contemporary compression materials. This is what we use today. Compression bandages like this. We have run-of-the-mill compression stockings, and the most up-to-date device on the market are medical adaptive compression systems. When we talk about compression bandaging, we have to be aware that this is often the reality. The road to hell is paved with good intentions, but this is reality. This is what we see when the patient comes to our practice treated with bandages. And this is a big problem because so we have more damage than benefit for the patient. Compression bandaging is a kind of a handcraft, an art form. It has to be applied by a very skilled physiotherapist or nurse or doctor, and includes padding and toe bandages, so that I will provide compression throughout the day. Only if I can provide all these fittings, it's possible to make a proper treatment. It's a difficult technique, and only a small number of compression bandages is still working when we see the patient in the evening. Medical compression stockings. We distinguish between circular knitting stockings for chronic venous disease, varicose veins, and also venous ulcer, and flat knitted compression stockings, what we use for lymphedema and lipedema and for special calibers. At the end, with those two types of knitwear, it is possible to treat, to apply a proper compression treatment with all the patients. Usually a seam on the backside indicates this is flat knit, as you can see on the right-hand side here. My first tip for you is use and prescribe donning aids. They make life easier for your patients and yourself, and they increase your patient's compliance significantly. Even a simple rubber glove can be a game changer. The point is, the best prescription doesn't work if the stocking is kept in the cupboard. It has to be worn, and so use these types of several donning aids and ask the patient which one is the best for him to use. Here you see the most topical development, adaptive compression systems. I will come back to them later because I think this is a revolution, and this is not that common at the moment as it should be. In this table, you see the pros and cons of each compression medium. CB means compression bandages. Advantages are they are suitable for all types of edema, and they are very cost effective. Disadvantages are a healthcare professional is required. This is not possible to manage for the patient himself. Self-management is difficult. And they slip during the day. What about compression stockings, MCS, medical compression stockings? They apply standardized compression. They have an optimal fit, and you can divide into stockings and shorts, capris, and you have circular and flat knitwear. And so you have a great variety of options to treat with your patients. The disadvantages are they only are useful after a decongestive therapy. You cannot treat your patient with an acute DVT with a compression stocking, because this stocking won't fit after the edema has been decongested. And then we have maybe a reimbursement problem. There are costs, especially flat knitted medical compression stockings and capris and shorts, and are quite expensive. And then we have the new adaptive compression devices. They make self-management easy. They are suitable for all types of edema, and they also apply standardized compression. I don't see a lot of disadvantages in Germany. The reimbursement at the moment is a little bit difficult, and so you have to wait to get the permission to prescribe that. But they are not more expensive than stockings, and if you have to apply a proper bandaging, it is also not that cheap as people of the health insurance companies think. So keep in mind, we have these adaptive compression devices. The next thing is to talk about is, what about compression classes? We distinguish into 4 different classes, and it's quite easy to work with, because different classes are appropriate for different disease, to make it easy. So a light compression stocking of class 1 with a pressure of 18 to 21 millimeters of mercury is a proper treatment for a chronic venous disease, for varicose veins, and it's sufficient in 80% of cases. A class 2 stocking, especially a class 2 round wound stocking, is the instrument you need for post-thrombotic syndrome, what you need for the first 3 months after DVT, but also for lipedema and lymphedema. But in these cases, you better use flat knit. But in most of the cases, class 2 is appropriate, but you can combine with other tools, and you can also use a higher compression class, especially for severe lymphedema. In a lot of cases, you need a compression class 3, what means 30 to 46 millimeters of mercury. How high is this? It seems to be very high pressure, but on the other hand, in a standing position, the vein pressure in an insufficient vein at the ankle is around 70 to 80 millimeters of mercury. So it makes the compression of 40 millimeters of mercury relative. What do the guidelines recommend? There are 3 papers I would like to draw your attention to. You see there is one current paper about the indications for medical compression stockings, one about the risks and contraindications, and then we have the 2022 guidelines of the European Society of Vascular Surgery. I start with the indications for medical compression stockings, and the authors of this paper conclude that there are 14 recommendations. They improve venous symptoms. They are appropriate for the prevention and improvement of venous edema, improvement of skin changes. They improve venous ulcer healing. they prevent of venous also recurrence, and there is an improvement of early side effects after venous intervention. And there is also an effect on the development of a post-thrombotic syndrome. And I have one table from these European guidelines I want to show you. In the green line, you see that we have a class 1 recommendation for elastic compression stockings with over 50 millimeters of mercury for venous symptoms. We have a class 1B recommendation for edema treatment with higher class, 20 to 40 millimeters, that's class 2. And we have a class 1 recommendation also for the treatment of skin changes. And on the right-hand side, you see the most important recommendations. It is class 1A recommendation for also treatment. So we always think about early endovenous treatment of varicose veins, and we spend a lot of money for wound dressings, and then we observe that there is no proper compression on these patients, and so we cannot be successful. You see, class 1A, it's the strongest recommendation you can get for compression therapy in leg ulcers. And the next thing is there are only few contraindications. Contraindications for, this is the conclusion of this text, contraindications are only severe peripheral arterial obstructive disease. Severe, that means we have a pressure below 70 millimeters of mercury maximum. This is severe. Another hard contraindication is severe cardiac insufficiency. In an outpatient setting, you only will see a severe cardiac insufficiency in very, very, very rare cases. Severe insufficiency means NIHA 3 and 4, patients that are unable to do any work, patients who suffer from dyspnea when sitting in their bed. These are patients with severe cardiac insufficiency. If they reach your practice, they probably will not suffer from severe cardiac insufficiency. And then it's always clear if there is an allergy to the compression material, you must not apply this type. Let's come to the practical approach. This is Alf. We talked about contraindications. He's a road builder. He has to work very strong and he loves his profession. And he has lymphedema on his right leg, and he also suffers from arterial obstructive disease, and he has this iliaco femoral popliteal bypass. On the right-hand side, you see the scars after this bypass. On the image in the middle, you can see that there is a veritable lymphedema. A lymphedema as a following this surgery, but this is what can happen. Now we have observed the patient, and he also has an ABI of 0.74 on his right leg. He has this this bypass, but the long-term result is not that good. On the right-hand side, you see that there are very bad arterial signals. But we have to treat both. So he is able to work and he wants to work. And so we have to help him. And so what we did is we started with decongestion of the lymphedema. And you can see that we could decrease the leg volume on his right leg. And we did it with compression stocking. We used a flat knit, but class 1 compression stocking. It's clear for lymphedema, a better way would be to treat him with the class 2 stocking. But because of these changes and this bypass, we decided to use class 1. And you can also see that the stocking doesn't belongs to the knee heel, because as a result of the scars, it was very painful for him in this era. He didn't accept a stocking at the knee, and that's why we had to do a shorter one. But we could manage that with a shorter class 2 flat knitted compression stocking. You have to vary in order to do the best for your patient. Here we have another case of a 52-year-old man who is suffering from prostate cancer and a veritable lymphedema of the right leg following oncological surgery. The recommended treatment options are manual lymphatic drainage, compression bandages, flat knitted garments, movement, skincare. We all know about that, but on the other hand, in the real world, he has to work 40 hours a week. He has family, and probably he has hobbies. This requires self-management strategies. And this is what we wanted to find out with a trial. I want to present you on one of the new adaptive compression devices. We conducted a multi-center study in 4 centers in Germany and Poland, and these are the preliminary results that we up to now we have already published. The primary endpoint was the independent handling of the new MAC system in the time frame from start till 6 weeks, and secondary endpoints were patient satisfaction and relief from discomfort, reduction of the clinical edema, and a volume of the lower limb. And we try to identify cost savings resulting from self-management of the need for an HCP service. Pitting edema was the most important inclusion criteria. Here you see the disease entities that were included in the baseline characteristics. The BMI and the waist to height ratio indicate that the majority of the included individuals were obese. And these are typical representatives of our study group. And I'm sure that you know this type of patient, and probably you see them also in your clinic every day. We conducted interviews to obtain the clinical scores and measured the leg circumferences and volumes using the so-called leg reader device. It is a device that enables you to measure the diameters of the leg contactless. It was very important as we conducted this trial during the pandemic, and so it was nice to be able to measure the circumference without touching your patient too much. And these are the results. The rep was fitted correctly by 91% of patients within the first week of use. More than 90% considered the rep to be very or fairly easy to put on. And more than 90% considered the rep to be very or fairly easy to put on. What about patient satisfaction? Green means satisfied or quite satisfied. Wear comfort after 6 weeks. Green again means it's comfortable or rather comfortable. And in terms of further use, 96% continued wearing the device always or intermittently beyond 6 weeks. once I have presented the results of the surveys, I will show you the results of the lymph ICF score and the measurement results. We can see clear and significant decrease in complaints in all categories: physical, mental, household, mobility, and social. This diagram indicates the degree of volume reduction during 6 weeks of use. And here you see that it works for all types of edema we included. And from the last graph, we learn that there is a higher effect in patients who didn't undergo compression therapy prior to using the REP. But the message is use the right compression tool. This is what we can see frequently. A 58-year-old lady suffering from lipedema, obese, and also secondary lymphedema. And in this case, circular NIT does not work. So you need to decongest her, and you can use reps for decongestion. And at the end, you can prescribe a proper NIT wear, and that's flat NIT in this case. Let's dive into another very realistic case from last week. Here we have a 72-year-old gentleman who has been suffering from a venous ulcer on his left leg since February 2022. We see severe reflux in the light reflex rheography. And this is our treatment plan. In addition to wound care and thermal ablation of the grade GSV, we performed a decongestion using ICP and a REP system. And that's very interesting. I want to recommend this paper from Dr. Mendoza, which came out during the last week. She could bring the evidence that manual lymphatic drainage can be replaced by intermittent pneumatic compression in lymphedema during the maintenance therapy. This is a very, very topical paper you can find in VASA, and I want to recommend it. And thank you so much, Erika, for this. So, and this is what we do. Once we have decongested using ICP, we use a REP. We use the CoolFlex REP, which is more or less like a tube. And you see my nurse applying this. And it's very easy. It is not a REP because we don't use these Velcro occluders. We use hooks, and you see seams. And these white seams are to indicate which compression is applied, and 2 lines means we have a compression class 2. And it took my nurse no longer than 1 minute for applying this REP. And this is what also is possible for the patient himself, as we could show in our ACRO trial. I want to conclude. Compression therapy is the basis of phlebological and lymphological therapy. There are only few absolute contraindications. Effect and compliance can be influenced by the selection of the compression medium, the material, and the compression class. And don't forget, keep in mind, compression class 1 works very well. Donning aids should be considered to improve self-management, and adaptive compression systems, so-called REPs, make life easier. MACs give patients with chronic leg edema a high degree of independence. The patients are satisfied and compliant with varying MACs, as we could indicate with our ACRO trial. And the devices are especially suitable for patients with edema related to obesity. They are appropriate for a very, very large number of patients. And improving self-management helps to cut down on healthcare costs. It is able to save your time in the practice and also for the patient himself. So thank you very much.
Thank you so much, Dr. Tobias. Really very interesting outcomes from your experience. I was actually really happy that we're part of the ACO study. And here I'm also to the audience, if you would like to have the details about the ACO study, of course, you can reach us, Dr. Tobias, but also our team from Survive Group, who is visiting you in the clinic, can also provide you a lot of information about the study and the outcomes. It was always a pleasure and also like one of our competencies that we deliver our knowledge in terms of conversion therapy application with the expert. So we like to work closely with the eminent and the professional expert like Dr. Tobias Hirsch to bring to life solutions can really help the patient to improve the outcome. So we look at the topic as more like a multidisciplinary approach to bring different stakeholder knowledge together and to make sure that's all at the end of the benefit of our patient. I will share now in the chat also from my side different links to keep you updated with subscribing to our newsletters or following our LinkedIn page or YouTube channel. But also, again, please keep in mind, training and education is what we can actually deliver the best. Our team are very well trained and willing to join you in your clinic with your nurses, with your staff, to make sure that everyone knows how it works, how we can apply the conversion token, how also the patient can take care of their legs, of their skin, different donning devices and donning aids to improve the outcomes. So use the team, use them in terms of educating your patient or your staff as well. So I think that was also one comment from my side. Again, thanks so much, Dr. Tobias. And now to Dr. Omar Farouk.
Okay, thank you very much, Dr. Tobias, for the best presentation I have ever seen on compression. And thank you for letting us know the MAC system for the lower limb. I have a good question from Erica. Please go ahead, Erica.
Yes, Tobias, I'm, as always, perfect presentation. You said something I didn't.
We can't hear you very well if you need the
Can you
mic.
put the mic? Yeah.
Sorry, my mic is gone.
Oh,
sorry.
Yeah, that's much better.
As always, Tobias, wonderful presentation. Thank you. Very clear. But I disagree in one point, and I want to ask what you mean. You said that the bandages are cheap. And I think this is not correct. Because if you take double layer bandages, which are in my eyes, this cohesive, the first layer and the second adhesive, so that it can stay 2 or 3 days, I made a calculation on the cost of 2 or 3 weeks of these bandages and then stockings versus an adaptive compression device. And if you include the material and the nurse going home to the patient and so on, it is cheaper to put an adaptive device from the first moment. The problem, at least in Germany, it is, I mean, the advantage is the public healthcare system pays for it, but it takes the administration 4 weeks to allow the patient to get it. So the gap in between, we have to bandage, and this is completely stupid. But if we could treat without money, the best thing would be giving the adaptive thing just from the beginning, because this is really cost effective.
Excellent.
I completely agree.
Yeah.
I agree. I completely agree because to apply a multi-layer bandage is not the same like apply one wounded fabrics. Yes, this is the problem. But this is very difficult to teach the health insurance companies. They only see that one bandage costs about 20 or 30 euros, and you need maybe 4 of them, and they compare that with an MAC, but they don't compare proper treatment with proper treatment. If you compare proper treatment, you have, the first thing is you need manpower. You need this healthcare professional who is able to apply such a multi-layer bandage, and so you cannot compare that. It's a lot of work for us to teach them about these news, yes, but
yes.
we have already started with this.
Excellent, very good. You know, surprisingly, I was reading a book about a month ago about the vascular diseases in animal. Surprisingly, giraffe, which is born standing and die standing, so standing 100% of the time, will never get venous ulcer. It's not been recorded, and they are standing the whole day. And the beauty about it, the author have done the biological design of the skin. It is very, very near to your MAC system. So this is really surprising because it seems this is a solution. You got different amount of pressure into different amount of the leg being compressed in the proper way. The giraffe skin is formed of 120 layers. That is why they never get venous ulcer. So I'm really excited about your new MAC system and the support from Dr. Mahmoud, and hopefully we'll have it in the market in Egypt, hopefully very soon. Let me take a question from the attendee. There is a question from Armia Sargeus. What are the contraindications for compression bandage? I think you mentioned in your slide, but I think they all want to know if anything else other than severe arterial ischemia, is there any other contraindication and allergy?
The contraindication doesn't depend on the device you use. The effect of the bandage, of a well-applied bandage, and an MAC and a stocking is always the same. But there is no Swiss Army tool where one fits for all, and so you have to use the best one for your special patient. But then you have to think about possible contraindication. And if your patient has severe heart insufficiency, you cannot apply a high degree compression using bandages, neither using other types of compression devices.
Yeah.
On the other hand, you are able to apply a gentle compression, fewer compression with a bandage. A bandage can be in your room, and you can immediately start. But probably the next day you have to think about the further treatment of your patient, as we all have to be clear that bandages are only a one-day solution, or the partner of your patient is able to apply that the next day again. But the contraindication does not depend on the device or the device you use. Yes.
Excellent. Thank you very much. We got another question from Dr. Nasser Al-Zahari.
Excuse me.
Yes,
I have
please.
a comment on that.
Yeah, please.
Yes. You have, for example, the most difficult situation, as Tobias pointed out, is the compression when you have an ulceration, because we have a 1A class. We can be sure that the ulcers need to be compressed. And if you have a mixed ulcer with arterial problems, I make two things. First, I use, there are compression stockings for ulcer patients where is a very, very slight compression understocking and a normal compression stocking. And I start convincing the patient that he can wear it with a very, very thin understocking, which is like 10 millimeters mercury of pressure, which is nearly nothing. And the second thing I do is I apply manual lymphatic drainage, because this decongests the tissue and allows a better arterial perfusion. In the moment that the edema leaves for the manual compression, manual lymphatic drainage, you have less pressure in the leg, and then the stocking is better tolerated. And you always should remember that patients with nearly amputation of the leg for arterial problems, they shall be given intermittent compression, because this improves the arterial perfusion also. So you can use this intermittent compression devices to reduce the edema, helping the arteries in the same situation. So I completely agree with Tobias that you cannot say it's impossible to use compression because you normally can do something if there is edema. Sorry.
Excellent. No. Thank you very much for your enlightening comment. So, a question from Dr. Nasser Al-Zahari. What is the duration of compression post-varicose vein ablation and post-acute DVT? How many days would you give compression, Tobias?
After varicose vein treatment, we conducted a trial, a synchronous trial, where the endpoint was the ablation, the additional ablation of the AASV, but we also observed the effect of compression, and we had the best results when patients received compression over 2 weeks after the treatment. A longer compression treatment after the ablation had no additional benefit. And so this finding, we included more than 1,000 patients into this trial. And the consequence for me was that from then, I recommended my patients to wear the stockings for 2 weeks instead of 1 week. Before I did this, I recommended them to wear the stocking for 1 week. And since we have known that from our own trial, and I trust in the results of our own trial, I always recommend them to use them for 2 weeks. But on the other hand, I'm a compressioner. I prescribe a lot of stockings, and we see a lot of patients who don't suffer from varicose veins, who never have had a DVT or post-thrombotic syndrome or something like that, but they work as hairdressers, nurses, teachers, or something like that, and they come back from home and they have problems, they have complaints. And for those patients, these patients don't need laser or radio frequency or whatever. They need proper compression. And in my case, we then prescribe class 1 below the knee stocking with a great effect.
And your comment?
This is what I would recommend. I recommend 2 weeks of compression after endovenous treatment.
And your comment, Erika? Yeah, please. Yes, Tobias.
When it comes to DVT treatment, DVT is another very important point. For DVT treatment, we know that class 2 is superior over class 1 stocking. And the most important point is to start as early as possible. If you have made the diagnosis of DVT, you have to start with the compression treatment with the intention of a better outcome with respect to post-thrombotic syndrome. And then after 3 months, there is no additional effect. Then the length of treatment depends on the complaints the patient has. If he has no longer complaints after 3 months, no edema, no skin changes, you can stop treating them with compression. But if you see the best results you have, and he says, yeah, but in the evening my leg is swollen, then you have a device in when using.
Okay, and your comment, Erika, how long do you keep?
I have nothing to add. It's perfect.
Yeah.
Tobias is it's completely my line. Yes.
Okay.
Completely.
Okay, that is
We
great.
are often in one line.
Yeah. Do we have more time for any more question, Dr. Mahmoud, or?
I think we can have like one last question, and then we would
Okay.
like to have also 1 minute take-home message from each speaker.
Okay.
But just to last one comment from my side, I think we all always following Dr. Tobias' recommendation when it comes to compression application.
Absolutely.
And we fully agree also from our side that it all depends on the complaints and symptoms. So there is no like time we said, okay, the patient should stop using the compression now or should use it for many months.
Yeah.
It depends, of course, on the progress, but also other factors of the lifestyle of the patient. Exactly as Dr. Tobias mentioned, that some of you have lifestyle or work profession requires standing or sitting the whole day, and that's also a high risk factor. And in this case, of course, eventually you will have some issues. So either as a prophylaxis or as a treatment, the conversion was always depend on the symptoms, but also on the complaints from the patient themselves.
Absolutely, absolutely agree. And I was told that we have hundreds of people on the Facebook watching our webinar, which is really exciting. So let me take opportunity to fire one of the last question. If you have a clinic, Tobias, and you want to put 3 compression devices that you commonly use that form 90% of your practice, what 3 devices will keep on your clinic, or you have everything in your clinic?
I have everything in my clinic, but to be honest, most of the devices we use are the cool flex,
Okay.
MACs.
Yeah.
But this is because we have conducted this trial, and it's very easy to apply, and we have a very good compliance with the patients. There are patients who are completely decongested and have already a prescription of stockings, but they come to me and tell me, no, I wear this this cool flex because it's easier to off and on. That's the point. Especially we have such a big number of obese patients, and they are suffering from edema. And for them, it's very easy to slip into this device. Yes, but this is most of our prescriptions are MCS stockings.
Okay.
But for the acute treatment, I would always use this.
Okay. What about
And
you, Erika? You have everything also in your clinic?
I have no adaptive devices in my clinic because we are not allowed to have them and to don them to the patients. But I have bandages for the acute situation. I have them here, and I have like stockings and flat knitted around. But I if I have a pitting edema, I bandage them. I look at them at 2 or 3 days later and then convert to the stockings. I would use far more adaptive devices. But I have the problem that the moment they are allowed to be given to the patient by the healthcare insurance, the problem is gone because they are bandaged and the edema is gone. So if I could choose like I wanted, I would use them far more often, the adaptive devices.
Excellent. So let me take the chance to have one final, let us say, grand summary of your presentation and your learning objective. We learned a lot from you, Erika, and from you, Tobias, today. I'm really very, very happy about this knowledge, which serve not hundred, it can serve millions of patients. As we are getting more and more older, this is extremely common situation. So if you can summarize to us, Erika, what you like the message to give us today, and after that, Tobias, and then I'll give the mic after that to Dr. Mif.
Okay, thank you so much for organizing in the first case and for inviting. Yes, my topic is you have to be sure when you make a venous investigation that you use the proper method to elicit a blood flow, and if you should use Valsalva and compression and some dynamic maneuver like the Paraná pushing the patient or toe elevation. And if you are in doubt, you can make this orthostatic maneuver. And you have to be very keen in defining where the reflux comes from and where it drains, perforating veins and so on. And as to my eyes, I'm sometimes called the queen of ultrasound because it's like my life, but I would never treat a patient based on the duplex result. I would only treat the patient based on the clinics the patient has and the wishes the patient has. And I use the duplex to have a tool to prepare my intervention the best possible fitting to the patient, but not to decide that I shall treat them. This is my
Excellent. That's
yes.
a beautiful summary of your presentation. And Tobias?
Thank you.
Yeah.
Once you have done a proper diagnostic using duplex ultrasound, and this is the heart of our diagnostic, you can immediately start treating your patients with one thing, and this is compression. Compression is a great standalone therapy for all phlebological patients, and it's a perfect add-on therapy for all the patients who need other treatments, from wound dressings over deep venous thrombosis and varicose veins. Compression therapy fits always.
Excellent.
This
Thank you
is
very
what I
much.
want-
And I would
That's my
like,
message.
I would like to thank you, Dr. Mahmoud, for this beautiful selection of webinar. You have gathered live streaming, technical skills, duplex ultrasound, Tobias guidelines on the presentation. Really, it's a fantastic combination, all due to your nice activity and nice enthusiasm in that field. And the mic to you, Dr. Mahmoud.
Thanks so much, Dr. Omar. Much appreciated. I'm really enjoyed a lot the MOH Connect, because this is a workshop. We call it under Label Connect. As you all know, the MOH is a dedicated platform to share knowledge and education among different stakeholders. So actually, it's your stage, it's not ours. Our role only is just to facilitate it, but all the knowledge, all the income, the content coming from the experts. That's why we have more than 70 events now on our webpage in different formats: articles, summaries, studies, one-pager, workshops, talks as a webinar, or even interviews in the future and the podcast. So I really recommend you to go through the website, the MOH.com, and you will find different materials, and it's all relevant, purely educational, without any commercial activities. So thanks again, everyone. I really appreciate the eminent speakers and their input that really helping us a lot to achieve our goal, to make or to be dedicated, to make everyone feel their best every day, as we say as a Grass Group. So thanks so much. I wish you a nice evening, and see you soon again in our upcoming event.